Next, I invite Dr. Rajashree Nambiar to present a case of, again, suspected choroiditis. She is from Little Flower Hospital, Angamali. Over to you, Rajashree.
Thank you all. As I begin with my case, the relentless march of the bug. This is the story of a 62-year-old female with no comorbidities. She was a vegetarian, no history of any pets. She was referred to us as a case of left eye panuveitis. She had a history of left eye cataract surgery in 2018, and then she presented 1 month ago to a local hospital where with defective vision, where a uvea workup was done, and she was diagnosed to have CME, and a posterior subtenon strikeout injection was given. Now this is the right eye, which was normal. Coming to the left eye, her vision was 3/60. She had granulomatous KPs with 2+ cells and PCIOL. Coming to the examination of the fundus, the media was very hazy due to vitritis. The disc could be seen very hazily. You could see a sclerosed vessel superotemporally. There were large areas of retinitis seen superotemporally at the macula and also nasally. We had a provisional diagnosis of viral retinitis and toxoplasma retinitis. This patient had been evaluated at the local hospital. Her investigations showed toxo-IgG showed a 3-fold rise in titers. IgM was negative, MAN2 was negative, VDRL HIV was negative. So we started our treatment with tab-valsivir 1 gram TID along with azithromycin, Visalone and topical medications. The next day, we took her for an AC tap, and the sample was sent for PCR for toxo and the viral genomes. The result came positive on the 3rd day for toxoplasma and negative for the virals. So we stopped Valsivir and started her on tab-Bactrim DS 1BD along with oral Visalone, and we also gave an injection of intravitreal clindamycin and dexamethasone. Now this patient, 1 week later, she presented to us. The vitritis had reduced. We could see the disc, which was more pale. We could see the retinitis patches. The edges seemed to be more defined, though there was a large lesion at the macula. Now she came back to us after 2 weeks. We again gave a repeat intravitreal clindamycin and dexa injection. Now this was a picture after her second dose. 2 weeks later, she again came back to us. She had severe steroid intolerance. So we tapered her oral steroids to 10 milligram, and we asked her to continue tab-Bactrim DS. We advised her to take a repeat injection, but she refused. Again, 2 weeks later, she came back with severe pain and redness. At this moment, she had severe amount of anterior chamber reaction with the 3+ cells, and the vitritis had increased. This was her picture at presentation. There was severe vitritis. Again, everything looked hazy. So we hiked up our oral steroids. We gave a repeat injection of intravitreal clindamycin with dexa. We stopped Bactrim DS and started her on tab clindamycin. And then she followed up after 1 month. Her vision was now only hand movements. Now this is her picture after 1 month. Again, details, everything looked very hazy. The retinitis patches, the patch of the macula, all were still present. So at this moment, we decided we need to revise our diagnosis. We advised the patient to go in for a vitrectomy and again a repeat PCR. But by then, the patient, I think she decided to go elsewhere. And then we did not have any other follow-ups. So this is the summary of her case at first presentation, following her first injection, and this is after stopping her steroids. So now I had a lot of doubts in this case. So first, could this be toxoplasma? Are we looking at viral retinitis? Why did the PCR come negative? Because she was an immunocompetent lady. The only thing was she was given oral steroid, posterior subtenon steroids.
So the PSC was given for cystoid macular edema.
Yeah, cystoid macular edema.
Yeah, so the thing is, if you don't do a careful indirect, you can very easily miss lesions in the back of the eye. And if you give PSD, then you can have, very atypical presentation. I assume that HIV was negative.
Negative. HIV was negative.
TPHA was negative?
Negative. VDR.
Yeah, so you got to remember that once you give PST, the effect is going to be there for a while. It's going to be there for 6 to 8 weeks. So, until the effect wears off, you're going to, I think people have even reported scleral necrosis in toxoplasma after PST. So, but you can see that, after you started clindamycin injection, there is a response.
Yes.
Yeah.
Yes.
So sometimes what happens is, large lesions like this, they take a long time to respond. And you also see situations where you have large lesions, where it will partly respond and then will not budge. Okay, no matter what you give, you can give Bactrim, clindamycin injections, it will stay as it is. So the only thing to do then is to go for a vitrectomy. Yeah, so I still think it could be toxo. Was there a scarred lesion
No, ma'am, we
in the
could never
macula?
find. No. There was a.
Do you have any OCTs?
Yeah,
to the lesion?
that was a we did not have a OCT.
You need to run OCT. I find OCT very helpful in differentiating lymphoma from other retinitis, because the OCT in lymphoma typically will show sub-RP deficit. In the early stages, it will look like drusen.
Yeah.
So you should not go for areas which are very elevated, because of the shadowing you will not see. So try to look for flatter lesions, which are in the middle. So try to get an imaging, you will get a better idea of what it is. Retinal infiltrates can happen in lymphoma as well, but choroidal involvement, no. But that will happen in toxo. Toxo can have, large lesions like this, they will be choroidal involvement.
So you feel, madam, you feel it as a peripheral toxo and flared up due to the subtenon. Yeah.
When you are in doubt, madam, do you give, Valsivir along with Bactrim DS? Because there was always a doubt whether we are looking at a viral or a toxo.
Yeah, when you look at the initial phase, there's absolutely no problem in giving, until one way or the other, you can give Valsivir plus Bactrim. And I tell my patients as well, it could be this as well, so I'm going to give you both. Okay. And once I have the biopsy results back, I'll decide, what to continue. So no harm in doing that.
And how reliable is toxo PCR?
Very, extremely reliable, provided you do it in a good lab. Any PCR is only as good as a lab which does it. But PCR in uveitis, I think, is best for toxoplasma and viruses.
These days, we are getting few false positive viral PCR.
Which one? Cytomegalo?
No, HSV.
HSV. So always
Few TB false positivity.
False positive. You always have to do a clinical correlation. There's no getting over it. You always have to correlate clinically.
Yeah, thank you, Rajashree. And the take-home message here is, before giving, especially local steroids like intravitreal or periocular steroids, rule out infection, especially peripheral toxo or viral lesion. That is very important.